Hello and welcome to part 4. Today we're going to talk about malignant ovarian tumours. So we'll just quickly go through the various tumour types. It's perhaps not all that important from a radiological point of view, but it's always good to have an idea of the tumour types if you're engaging in a conversation with the gynaecologist or pathologist and you want to hold your own. So the majority of primary epithelial malignancies will be, primary ovarian malignancies will be epithelial in origin. That is, they will arise from the surface layer of the ovary, which of course facilitates spread around the peritoneal cavity, and that's why these tumours unfortunately often present late with transperitoneal spread. By far the commonest histological type is serous carcinoma of the ovary, and that can also present as a serous cystadenocarcinoma depending on the extent of cystic component. Now, just to note that some people believe that these tumours can arise from the fallopian tube epithelium, and therefore even if you had your ovaries removed you could still get a serous carcinoma. So just bear that in mind if your patient has had oophorectomy, not to entirely discount this diagnosis. And as we'll just mention again in a minute, we can of course get primary peritoneal carcinomas as well. So the second commonest tumour type that you might find of a malignant nature in the ovary is borderline adenocarcinomas, which are relatively low grade and slower growing. Some people say that the primary lesion is more cystic than solid elements, but generally speaking this is a histological diagnosis. I'm just going to mention mucinous carcinoma or mucinous cystadenocarcinoma, again depending on the extent of cystic component. These are not that common, but they are of some interest radiologically because they are often calcified, and of course calcified tumours can produce a characteristic appearance on CT, which is very sensitive to calcification, and calcification can be visualized but can also be difficult to see on ultrasound, as it can be dismissed as being bowel gas, and it can also be difficult to see on MRI. It's easy to miss low signal calcification. These tumours can also be metastases rather than primary ovarian tumours arising from the gastrointestinal tract or sometimes the breast. Endometrioid carcinomas can arise in endometriotic remnants, that is, remnants of endometriosis, and they can also arise in association with endometrial carcinoma in the uterus. So just to bear that in mind, because of course an endometriotic deposit in the ovary, or indeed anywhere else in the pelvis, will usually become quiescent after the patient undergoes menopause because there's no longer any hormonal stimulus, but they can undergo malignant degeneration to endometrioid carcinoma, or in fact also to, there's another histological variant, clear cell carcinoma, which can arise in endometriotic tissue. But we don't need to worry too much about those really. Let's just talk next about malignant germ cell tumours. So malignant germ cell tumours often present in the teenage years as opposed to epithelial tumours, which present more commonly in postmenopausal patients. Now, one of the things I just forgot to mention a minute ago was the tumour marker which we might see in epithelial ovarian cancer, and that of course is CA125, which you may have heard of. CA125 is a rather non-specific tumour marker. It can be seen in many benign conditions throughout the pelvis, such as endometriosis, or even in pelvic inflammatory disease, or it can be seen in primary tumours elsewhere in the body. For example, a primary lung cancer may produce an elevated CA125, but nonetheless it does have some association with primary ovarian tumours, and it's frequently measured when primary ovarian malignancies are suspected, so it's just something that you might want to be aware of. That just brings me on to mention that there are also tumour markers seen in association with malignant germ cell tumours, and those are alpha-fetoprotein and beta-HCG, so you may see those mentioned as well. So Germ cell tumours in the ovary are not all that uncommon, but the vast majority of these are mature cystic teratomas or dermoid cysts. So these are benign tumours, and we'll discuss those in depth in a later video. But just quickly, the malignant germ cell tumours, they can be dysgerminomas, which are the female equivalent of a seminoma. They're generally solid. There can be immature teratomas. They can display all the usual germ cell elements like hairs, sebaceous cysts, fat, that sort of thing. They can be difficult to tell from their more benign counterparts. And then we can have yolk sac or choriocarcinoma tumours, which are highly malignant, and some mixed tumours. They usually present in the teenage years, and they are often large masses associated with pain. There's often torsion involved, whereas the epithelial carcinomas, they tend to present with insidious dissemination of the tumour around the peritoneal cavity, which often causes the patient to have weight loss and vague gastrointestinal symptoms, which is why they come to medical attention late. So that's really all I want to say about malignant germ cell tumours. The third type of malignant ovarian tumour which we encounter is stromal tumours. The stroma is the supporting network of tissue within the ovary, which holds the epithelial lining and the germ cells together. And these are, for example, the granulosa cell tumour, which can produce estrogen, and the Sertoli Leydig cell tumours, which can produce testosterone. So it's just worth mentioning these because they are functional tumours, and they do tend to occur more in the postmenopausal patients. So a patient who has postmenopausal bleeding, you might be scanning them looking for an endometrial carcinoma, but in fact the cause might be a granulosa cell tumour. They're generally relatively low-grade tumours, and they're usually solid masses. And of course, in younger patients, they can cause virilization in premenopausal in patients who have prepubertal patients. Just going to mention primary peritoneal carcinoma, which we touched on earlier. You can get a carcinoma which disseminates in a relatively similar manner to primary epithelial ovarian tumours arising from the peritoneum without a primary ovarian mass. And you might see this sometimes on a CT scan. A patient comes in, we have a CT, there's a omental tumour present throughout the abdomen, but there's no clear ovarian mass, there's no clear evidence of a metastatic site. Often this is a primary peritoneal carcinoma. Metastases, that's something that's very important to remember as a diagnostic possibility, because what we don't want to do is assume that an ovarian mass is a primary tumour, remove it, and then find that the patient has an underlying malignancy somewhere else. So whenever you see an ovarian mass, particularly large bilateral ovarian masses, always think about metastases, and the commonest tumour sites are stomach, colon, breast, and pancreas. And we know that these are called Krukenberg tumours, and they were classically described as metastases from the stomach. But when you see these on a CT scan, then quickly put your eye over the stomach. It's difficult to look at the stomach on CT because it's often collapsed. If there's a very obvious full thickness carcinoma, you might see it. Check the colon out. Usually if the colonic tumour is large enough to cause the ovarian metastases, you will see the primary tumour. You may or may not have the breasts included on your scan, and you may not see any primary breast carcinoma, but have a look anyway. And the pancreas, of course, is very well seen on CT, so have a quick look in there. So check out those possible primary tumour sites wherever you see what looks like a malignant ovarian mass on CT or on MRI. Obviously you probably won't be able to identify these on an ultrasound scan. And just if you are doing CT or ultrasound and you come across an ovarian mass, just remember that the presence of parenchymal liver or lung metastases is unusual in ovarian carcinoma, and we should consider primary tumour elsewhere. Now there are some ovarian carcinomas, for example some germ cell tumours like a choriocarcinoma, where you will get lung and brain metastases, but in the standard epithelial carcinoma, there's generally quite a standard route of spread throughout the peritoneal cavity, the lymph nodes, the serosal surfaces of the bowel and the liver and spleen. It's rare to have intrahepatic liver metastases or lung metastases, so always ask yourself, is there a primary tumour somewhere else? I have seen a couple of lung carcinomas which have spread to the ovaries as well, but again, it is quite rare. So this is probably our most important slide. I think we discussed in the physiological cysts video some of the classic features of those physiological cysts, such as the peripheral flow and the smooth borders. These are the signs which you want to really note down and be looking for these all the time in order to identify a malignant ovarian tumour. Now, a lobulated mass is a very suspicious finding in an ovarian cyst or ovarian solid mass. Having a smooth border it doesn't mean with certainty that the lesion is benign, but it's certainly quite reassuring. If you see an irregular or lobulated border, that's a strong sign of malignancy. Solid elements in the mass, in the ovarian lesion, which are having mass effect, that is pushing parts of the ovary to one side or pushing adjacent structures away, they are another sign of a malignant ovarian tumour. Internal contents with vascular flow. So peripheral vascular flow is, as we saw, associated with physiological cysts, but an internal mass containing vascular flow is usually due to tumour of some type. Clearly, a progressive increase in size over time leads us to believe it might be malignant. We do have increase in size of hemorrhagic cysts over time, but they should ultimately resolve. And as a general rule, larger size means more likely to be malignant. So let's look at some pictures now for most of the rest of this video. Here is a large ovarian, or what I would say pelvic mass. It's hard to tell where it's coming from at the moment. I'm just going to get a pen here. So this lesion here, this is a transvaginal scan. We can see from the characteristic appearance of the probe face, and this is therefore this is probably about 10 or 11 centimeters solid mass. We're immediately thinking this is likely to be a malignant tumour, and you can see here it's got a lobulated border to it. So this here is very suspicious for a malignant tumour. Now the second feature of malignancy which this mass demonstrates is internal flow within the solid elements. So this is a solid mass, and we can see that there's internal dense flow within it. Now just going to now, it's always a bit tricky to evaluate flow, especially when you're looking at somebody else's pictures, because if you shake your hand, you might produce an artifactual appearance of flow, especially if you're using colour Doppler. So how do we know what's genuine flow from what's perhaps artifactual? Well, certainly identifying a branching pattern like this. If you see that sort of appearance, that tells us that it's most likely to be a genuine flow pattern that we're seeing inside the mass. We can just see a little bit of flow, a little bit of branching pattern here. So this tells me that I'm very convinced this is genuine flow. Now really deep in heart of hearts, I'm pretty sure this is convincing too, but sometimes it can be tricky, and if you just see these sort of areas here, perhaps, if you shake your hand around when you're taking the pictures, you can often produce this sort of artifact. So this branching pattern is what we're looking for. You won't always see it, but it's certainly something to be looking for. We'll see it again in a second. Here we are. Here's an example of that branching pattern. So this is really very, very convincing for a malignant ovarian tumour. This is strong colour flow within the lesion. So we've got strong colour flow, and we've got an irregular border, large size. This is going to be a malignant tumour until proven otherwise. You can just see the bladder here in the corner. And here's the CT on this patient. I actually thought this might be a primary bowel tumour when I saw the CT scan, but in actual fact the patient underwent endoscopy, and you can see it was a primary ovarian malignancy which was actually growing through the wall of the bowel here, as you can see on colonoscopy. Here's another patient with a primary ovarian malignancy. This one's a bit smaller. It's again a transvaginal scan, and you can see that these solid elements internally are pushing out like this. They're not concave in, they're rather pushing out. And this part of the border certainly does look smooth here. So this this border of the lesion is quite smooth, but there's something funny going on over here outside of our view, and we're not quite sure what's going on here. I'm not sure, and we've got very dense flow internally. Okay, so this rather looks a little bit lobulated, perhaps out there. We're not catching the edge of it, and this is why it's important to try and interrogate the whole lesion if you can. Again, we have dense flow there with a branching pattern. Now, they're not always as easy as that, of course. Here's a patient with a slightly lobulated border, but it's very, very difficult. I'm not going to say this is very convincing for a lobulated border, but perhaps you might agree once I've outlined it like this. This is a sort of pattern which is often seen actually in endometriosis or in a patient with previous pelvic inflammatory disease, where fallopian tubes are pulled in and sort of mixed up together with ovarian stroma, and it can be very difficult to evaluate. This patient did undergo MRI, which I think we have here, and you can clearly see that this is a solid ovarian mass with a cystic component, and this is a very irregular margin here. And this is the classic appearance of a malignancy. And you can see here, there's something odd going on there. We can just zoom in on that on a high resolution T2 scan. So this is a T2 scan of the pelvis. Here's our general T2, a little bit of fluid there. Here's our bowel. Here's our vessels. And we've zoomed in with a nice high resolution T2, and you can see this is actually tumour spreading directly into the peritoneal fat next to the ovary. So this is a malignant ovarian tumour. But it wasn't very obvious on the ultrasound. It was quite difficult to evaluate. Here's a peritoneal tumour deposit, which we can see in the pelvis, same patient, and this is outlined against this fluid. So if I was just to go back here, this just isn't very easy, is it? There's not much flow internally. There's a solid element, some cystic component, slightly lobulated margin, but not very easy. Here we are again with a solid ovarian mass, and you can see this is relatively smooth border to it. So otherwise you might say that was a rather benign border, but there's vascular flow internally here with a branching pattern indicative of a malignant tumour. So we consider this to be a malignant tumour. Here's another patient with a rather difficult to evaluate solid lesion. You might say this could be a blood clot internally because it's rather concave. But internally there's flow within the solid component of the mass, and this was a primary malignant tumour. Here's another patient again with something which could be construed as being clot. We're not seeing that border very well over there, but certainly this part here looks nice and smooth. Solid mass internally. It could just be blood clot from a hemorrhagic cyst, but when we look at the colour flow we can see that there's convincing flow in here, and this was a malignant tumour. Now I'm just going to say something which perhaps is obvious, but if your patient is postmenopausal, if they're 65 years of age and they have an appearance like this, then it's not going to be a hemorrhagic cyst, because patients who are 65 years of age don't ovulate. So that's perhaps an obvious fact, but something to bear in mind when we're interpreting scans on these patients. Just going to put up a quick picture which we saw in our earlier video, just to contrast the peripheral flow that you see in a hemorrhagic cyst. Here's another hemorrhagic cyst, and you can get the flow within septation areas here like this, because the hemorrhagic cysts can be complicated. I'm just going to bring us back where you can see the central flow in this primary ovarian tumour. And of course you can see some peripheral flow as well sometimes, so it's not easy. What you have to do is take the principles and try and just gain experience in your own practice. Here we are with the margin again. I'm very keen on the margin. I think it's a really helpful sign. It's not perfect as you've seen in some of these cases, but here we have a nice smooth edge to this lesion, but suddenly it stops. There's a solid component, and you can see the lobulated margin there. And this was a malignant ovarian tumour, and the patient actually had extensive metastatic disease. Here's a patient with a large mucinous carcinoma. So this is actually a transabdominal scan. This was large enough to see on a transabdominal image, and here we are on the transvaginal scan. You can see large tumour with irregular contents internally, and this is the sort of appearance that you often see, the sort of mucinous appearance that you can see in these tumours. Here's that patient. You can see a focus of calcification within the lesion, and that's a characteristic finding that you see in mucinous carcinomas, and we'll see that in future videos as well. Now I just want to say one quick word about the sampling of these lesions. I mentioned that it's very important to try and see the whole of the lesion in order to adequately assess it. Now, many of the previous guidelines have said that in lesions greater than 10 centimeters, you should perform MRI in order to fully evaluate the cyst. But I think in recent years, and I've certainly seen this at recent RSNA meetings, that the emphasis is rather on you making up your own mind about that. If you can see a cyst completely, even if it's large, and you can't demonstrate any malignant features in it, you think it's benign, then that should count as a satisfactory evaluation. The important thing is that you interrogate the whole of a cyst before you make a conclusion. If you can't evaluate it completely, then you're really not in a position to be sure what its internal nature is. And that's just illustrated here. This is a patient with lymphoma recurrence. So she had a recurrence of what looks like lymphoma in her para-aortic area, confluent lymphadenopathy. And she also had a pelvic mass, and I thought I'd biopsy this because I thought this would probably be easier than doing a CT-guided biopsy. So took her in for a transvaginal scan, and I looked at this and I thought, well, sometimes lymphomas are very low echogenicity. It probably just is still lymphoma, but I was slightly doubtful. I thought I'd better just put my local anaesthetic needle in all the way to see it, just to check it was solid, but in actual fact it was cystic. So I thought perhaps it's just a very large benign ovarian cyst, but then I did remember that it didn't look really like a pure benign cyst on the CT. So I had a good look around, and then at the very bottom I saw this solid area, which I was able to biopsy, and this was a carcinoma of the ovary. So the patient had carcinoma of the ovary, and then we subsequently biopsied her retroperitoneum, and that was lymphoma as well. But it just goes to show you that you have to fully evaluate the lesion to make sure there's no solid elements hanging out in the corner. Here's a patient with a who had normal ovaries. I just want to emphasize how you can get things wrong in your colour flow assessment. So unfortunately I don't have any pictures here without the calipers on, and I always tell people it's really important to try and take some pictures with the calipers off, so that people who might review your scans in the future can get a good look at them without these irritating markers on. This patient I think had some bloating. She came for a scan. Ascites was noted, so immediately, of course, there was a query as to whether the patient had an ovarian malignancy. These are the ovaries. So this is a rather normal looking ovary here. It's only a couple of centimeters in size. It's got a smooth border to it, and this is just normal looking ovarian stroma. It's only a couple of centimeters. But the person, you see, has the gain turned up very high. You can see this colour flow coming in from everywhere here. We shouldn't really be seeing colour here or here, and they call this a malignant ovarian tumour because they had the gain turned up excessively, I would think. Of course I wasn't there, I'm only able to go in their pictures, but they I think had the gain turned up excessively, which is producing colour flow out here in the middle of the fluid, which we shouldn't really have, and there's a spot of colour here and a spot here. So I don't really believe this is genuine malignant flow, and it doesn't show a branching pattern either. And there's the patient's uterus, there's the bladder, and ascites. So the patient went on to have a CT scan, which did show lots of ascites. Not a very good quality scan, but there was no omental tumour identified. Unfortunately, they haven't given oral contrast here, which is a bit disappointing. It's always nice to give positive oral contrast in these cases. But this was a portal venous phase scan, so 60 to 70 seconds after, 70 seconds should I say, after the injection of contrast, and you can see we've only got arterial flow here, so it's a very arterial phase scan. And when we get back up to the heart here, we can see there's quite a lot of ascites, and we've got grossly dilated hepatic veins and a large IVC, bilateral pleural effusions and a large heart. This patient had heart failure, and heart failure, of course, is a common cause of ascites. And so this patient came with ascites. There was an immediate jump to the conclusion that they must have ovarian malignancy, of course, finding a bit of colour flow on their scan sent them to the Gynaecological cancer meeting. So just remember that ascites, while it is a sign of ovarian malignancy, it doesn't mean that you have ovarian malignancy. And whenever you see ascites in a lady, always also think heart failure and cirrhosis, because they are two other possibilities. And patients, once they get labelled with something, they can find themselves going down a road which can lead to unfortunate invasive procedures being performed. And we don't really want to perform surgery on patients who are in heart failure, and we definitely don't want to perform surgery on patients who have cirrhosis, undetected cirrhosis, who of course have a very high operative mortality if they have decompensated liver disease. So by all means, when you see ascites, look very carefully for a primary ovarian tumour, but don't give the patient a diagnosis without justification. Here's a patient who's also got ascites. Here's some ascites anterior to the uterus, and we've got some posterior. Here's an intrauterine contraceptive device, the transverse portion, and these are the broad ligaments. So what would you think about this patient's ovary here? Think about the last patient. I think this lady was probably just in her late 40s. You can see clearly there's a very irregular margin, lobulated contour to this ovary. So this is malignant tumour here. Here's our CT scan. You can see that malignant tumour of the ovary with ascites. And we're just getting on now to discuss omental tumour, which is, as we said, omental and peritoneal tumour is the natural spread pattern of ovarian carcinoma. We'll talk about it more in a later video, but just to show you, here's the anterior, here's a transabdominal scan, quite a lot of ascites, and here we can see some omental tumour. I'm just going to draw on it here so you get an idea where it is. So that's probably our omental tumour here. And of course behind that, as we'll see in a minute, you're going to have some bowel. So we've got ascites here, we've got a omental tumour here, we've got bowel here. We're going to have to get some tissue on this patient, and often we try and get a biopsy, a percutaneous biopsy of the omentum. So what's important here is, just go on a little bit, here's our patient with ascites, omental tumour here, and here's our ovarian mass. Now what's important is that we're going to be asked to get some tissue. So having a bit of cytology from the ascites is not going to be good enough, even if it shows some malignant cells. In this day and age, the oncologist is going to want a piece of tissue because they're going to want to do some special stains on it, which I don't really know about, but I know they want to do them. And they might also want a fresh sample because they want to put that sample away, and they want to be able to refer to it in the future if new chemotherapies are developed, and they want to be able to do genetic analysis on it. So they will be asking us for a piece of tissue, not just a bit of fluid. So when you come across this patient and you see them, if you're asked to drain their ascites, don't just drain the ascites, don't just put a drain in here and relieve their symptoms. You've got to do the whole job and get a piece of tissue. Now you can get it from here, should be able to get that with ultrasound. But what will happen is, as soon as you drain the ascites, all this will collapse away, and this ovarian mass here, or the omental tumour, will fall backwards on the bowel, and it might be very difficult for you to obtain the tissue sample. So always get your sample if you can while the ascites is present, because the ascites is a very good, even though it's further away, the ascites is a very good window for your needle, and it will make it much easier for you to get a sample. So make it one visit for the patient, get the sample and get their ascites drained when they come through. And that's a very common clinical scenario. And often, unfortunately, what happens is the patient comes in, an ascites drain is requested, and somebody drains the ascites, easy job of course, 5-minute job, and they don't get the biopsy, and then we have to come back and try and get a biopsy later, and it's much more difficult. So this patient here, we've identified some mental tumour, we've identified that ovarian mass here, and when we look at her spine on the CT, you can see here extensive sclerotic metastatic disease with a couple of vertebral body collapses. As I said before, this is a very unusual pattern for primary ovarian carcinoma, and in fact this was metastatic breast cancer. Here's another lady who presented with large bilateral ovarian masses. These were assumed to be primary ovarian malignancy. The patient showed up at the Gynaecological multidisciplinary meeting. But of course, there was a primary pancreatic carcinoma here, which hadn't been appreciated on the imaging. And there's a nice, sorry, I shouldn't say it's nice. There is a peritoneal tumour deposit which is suitable for biopsy. And it was easy for one of my colleagues just to take a biopsy from this sample with no morbidity for the patient. And of course, the problem with taking a sample here was it might have been difficult to identify a solid area in which to get good tissue. We might just have got some fluid and a small bit of tissue. The pathologist might not have been happy with that. But this area here is very good for a biopsy because it's solid tissue, it's close to the surface, there won't be any morbidity here. We just have to watch out to make sure we're not going into one of the superior epigastric artery, but we should be okay there. And that was a primary pancreatic carcinoma. So the management obviously is completely different. We don't want to be removing these ovarian cysts and leaving behind a pancreatic carcinoma. That would be a disaster. So that was just a quick run through primary ovarian malignancies and a few words there on metastases as well. But of course they're not easy to identify. We've mentioned large size, irregular margin, colour flow, those sort of things. But what we do need is a sort of a criteria which we can use to grade in order to categorize tumours into benign or malignant, something that's rather reproducible. And we have two systems with which we can do that. One is the Iota system that was developed in Europe, and the other is the ORADS, which has been more recently developed in the United States, and they're both pretty good really. So the Iota criteria, what we've got is we've got 6 benign and 6 malignant features on ultrasound, and we should look for those. And if you have 1 benign and no malignant, then it's most likely to be a benign lesion. If you have 1 malignant and no benign, then it's likely to be a malignant lesion. But unfortunately, if you have no features, or if you have features of both malignant and benign tumours, then it's indeterminate. The ORAD system, which I think is perhaps less helpful in the descriptive features, but probably more helpful in the management, is just a simple 1 to 5 grade. So these are the Iota criteria, and here are benign features. So if it's a unilocular cyst, presence of solid components which are small, that's diameter less than 7 millimeters, acoustic shadows, smooth tumour with largest diameter less than 10 centimeters, and colour score 1. So colour score 1 to 4 is a sort of a subjective interpretation of the colour flow. So then we have our malignant features: irregular solid tumour, presence of ascites, 4 papillary structures. So papillary obviously is this sort of pattern like this, that shape there. Finger-like is what we might call papillary. Irregular multilocular solid tumour, and very strong blood flow. And we've seen examples of some of these earlier. And I think the irregular margin, which I was talking a lot about, is what you would find described in this one and this one here. So these are useful. These are reproducible features which you can find, and so this is quite a helpful criteria. And so what you can do is you can look at an ovarian lesion, you can measure it up to these and see if it satisfies these criteria, and then you can give an opinion, and then you've at least made an objective assessment of the lesion. And that's very much appreciated, because if you say it's Iota benign or Iota malignant, then I know how you've assessed it, and vice versa. So it's helpful for inter-observer reproducibility, and it can help us to cut down on saying Malignancy is not excluded, indeterminate ovarian mass, or complex ovarian mass. These are all terms which you should just never use. You should never say it's indeterminate. You should never say it's a complex ovarian mass. You should never say malignancy cannot be excluded. We should try and say it's either benign or it's malignant, or by Iota criteria we can't say it's indeterminate. There's nothing wrong with doing that. But we should always try and, if we can, give some kind of opinion on it. So Iota helps us to say benign features, malignant features, or indeterminate. ORADs, which I don't know if you'll be able to see this very clearly, this is rather similar, but it just gives perhaps more prescriptive features, and it tends to be it has more information on specific diagnoses and how they should be managed. So here we are. Size, non-simple unilocular cyst, smooth margins, that sort of thing, solid component, and it gives relative risks. So this also, and there's actually also an app for this, which is available on Android and Apple. You can download that free. It's from the American College of Radiology. If you search for that, you'll be able to find it. It's quite a useful app, and it takes you through how to diagnose the lesion, and it helps you perhaps to get a better idea of management than the Iota. I think they're both very good, and I think it's rather a matter of personal preference which one you can use. But I would try and use one of them if you can, because they give some validity to your opinion. Okay, so I think we'll call it a day there, and we'll talk perhaps a bit about benign ovarian lesions in the next talk. Thank you.